Thank you all for the invitation to speak about what's happening in genomics in Estonia. And indeed, we are trying to set this up on a national scale. So I'm head of the Estonian Genome Center, which is focused on the research around the Estonian Biobank. And I'm also working on research in pharmacogenetics myself. So regarding the history in Estonia, the Estonian Biobank was founded in the year 2000. After passing the Human Genes Research Act, which has been instrumental in protecting the privacy and data security for all of the biobank individuals and samples. And there was a first initial recruitment campaign, which lasted about 8 years, and they recruited 50,000 samples and then started recruiting scientists, and that's around when I joined the Estonian Genome Center. And then we had started different research projects and running genome-wide association studies and just findings associations between different genetic variants and diseases. And based on different findings, we started recontacting participants and returning results and together with genetic counseling. Gradually, this started to catch good ground and good attention from the government, and we got funding to recruit an additional 100,000 individuals in 2018 and a further 50,000 in 2019. So the current cohort size is 200,000 individuals, and that's 20% of the adult population in Estonia. And we're also launched a national personalized medicine initiative for implementation of genomics in the clinic. So these 200,000 biobank participants have all been genotyped using the global screening array from Illumina. We have also sequenced about 3,000 whole genomes. And to date, more than 5,000 individuals have actually received return of results as part of different research studies. And personalized medicine around the biobank is centered on this population-specific whole genome sequencing reference panel. And we use this to impute rare variants also into the genotype data. And using this imputation and long-range haplotyping, we can then analyze the effects of rare and common genetic variants in disease and like familial hypercholesterolemia, which affects about 1 in 200 individuals who carry genetic variants in the LDL receptor, ApoB, or PCSK9. And this is associated with abnormally high cholesterol levels. And it's considered one of the most common monogenic disorder. And familial breast cancer is more known with breast cancer mutations in the BRCA1 and BRCA2 genes, which is also has a similar frequency. So our first test was to look at the sequenced genomes and exomes, and there we identified 41 mutation carriers in these genes. And out of these, actually only 3 had the correct diagnosis prior to the study. Half of them had some kind of hypercholesterolemia or dyslipidemia, but they had no idea about the familial background. After the study, at least 37 had confirmed familial hypercholesterolemia, 2 had variants of previously unknown or confirmed effect, and 2 definitely did not get the diagnosis validated. Although half of them had some kind of diagnosis prior to the study, only 1/3 was actually taking the necessary treatment to lower the cholesterol levels. So this is statins treatment. After the study and visits at the cardiologist's office, this was doubled. So 66% started preventive treatment, and an additional 20% could hopefully soon also start treatment. Some had contraindications, or pregnant or breastfeeding, and wanted to just wait with starting the treatment. So these are now under follow-up by the clinicians, and we are also looking into follow-up data 2 years past the study to figure out how many of them have then adhered to the treatment recommendations. For breast cancer, we actually had a similar picture. So 22 mutation carriers were identified. And although 17 of these individuals had a family history of breast cancer, only one had been referred to a medical geneticist prior to the study. So unfortunately, two had already been diagnosed with breast cancer and two with prostate cancer at fairly young ages. But the major conclusions of both of these studies is that there is an unawareness of the familial background of these diseases, both among the individuals in the population, but also among clinicians. And there is a low pre-established treatment adherence for prevention. And I think the greatest value of both these studies was that after that, both cardiologists and oncologists really acknowledged the value of this genetics first approach as an additional aid for identifying individuals at high risk for these diseases. But as I mentioned, these are rare, fairly rare conditions. It's affecting about 1% of the population, but common complex diseases such as cardiovascular disease affects a much larger proportion of the population. And we have, through these genome-wide studies, found hundreds of genetic variants that are associated with different disorders. But the problem is that the effect of every single variant is very small. So the new hot topic is now to combine these genetic variants into polygenic risk scores and focus on the normal distribution of these polygenic risk scores and focusing on the individuals at exceptionally high genetic risk, whether it's 10% highest or 5% or 1% highest risk, and looking at the prevalence of disease or incidence of disease in these high risk groups. So here is just an example of incident myocardial infarction and actually its interaction with lifestyle. So here's an example of individuals in the 20% highest genetic risk score in red and whether they are smokers or not. So red are smokers, and you can see that the effect of the polygenic risk scores. Okay, so this was the slide of polygenic risk score and the 20% highest risk. So in red, you see the ones who are smokers, and in the dashed red line, you see those who are not smokers, but in the high polygenic risk score. And you see that the effect of the risk score is here coming out among the individuals with the poor lifestyle choices. So we are now running several studies to both evaluate the clinical utility of polygenic risk scores for detecting individuals at high risk of disease, but also for using these tools to counsel people to improve their lifestyle. And here's also a clinical study going on for polygenic risk scores of breast cancer, where we also see a much higher incidence of breast cancer among the individuals in the top 5%, here in the orange line. And normal screening in Estonia for breast cancer mammography is offered for from the age of 50. And in blue, you see the reference population. And what you can see is that this top 5% individuals, they actually reach the same risk level already at the age of 35. So although it doesn't make sense for a healthcare system to offer testing of all females from the age of 35, then screening 5% of the individuals or 10% of the highest risk individuals from the age of 35 seems to make sense based on this study. So really what these observations that we have based on the polygenic risk score is that in 20% of the cardiovascular deaths are actually among the individuals with the 5% highest genetic risk, which is 4 times more than you would expect. And this is similar to what is observed for monogenic variants that are evaluated in the clinic. And the final bit where we have discussed the implementation of genetics in the clinic is pharmacogenetics, or prescription of medicines. And here we see, based on the Clinical Pharmacogenetics Implementation Consortium, with published guidelines for carriers of different genetic variants. And when we took all the biobank samples and translated their genetic data into treatment recommendations, we found that 98% of individuals carry genetic variants that affect drug response. So this is the kind of pharmacogenetic reports we have created for all the biobank participants. It's based on if they are slow metabolizers, and we have had examples of individuals who have actually been prescribed these medications and have severe side effects. And now the next step is not only to make this available for the biobank participants, but also we have a PERMED project funded by the Regional Development Fund, and Estonian government launched this program to get this information into the clinic. And of course, there's a lot of work of validating and replicating these findings before they can be used in the clinic. But in parallel, a lot of IT development is necessary as well, so that these pharmacogenetic recommendations can actually be part of the digital prescription that is used in the healthcare system in Estonia. And finally, we also have a biobank portal research portal for the biobank participants that is launching next year, so that they can actually log in and get recommendations for how to manage their health, how their genetic risk and lifestyle interact, and really putting a lot of focus on how they can reduce the risk for disease based on changing their lifestyle, rather than worrying about their genetic risk alone. So there's a lot of people working on this, and I'm really sorry you couldn't see my slides in the beginning, but thank you for your attention anyway.